Bismillahirrahmanirrahim. I am grateful to the organizers of the Pakistan Society for Rheumatology to invite me to speak on Behcet's disease. It used to be known as the old Silk Road disease, hence the title. I'm Dr. Mohammed Saeed from Immunocure, which is an autoimmune disease center in Karachi, Pakistan. And we provide comprehensive range of clinical services and laboratory services for autoimmune disease patients, as well as we are focused on autoimmune disease research. You can visit us at www.immunocure.bk. Here are my disclosures. So the first thing to untangle is the name itself. So it was Professor Bechet, who was a Turkish dermatologist, who described the disease that we are going to discuss today. His name is confused in terms of pronunciation with another eminent dermatologist of French descent, Paul Bechet, who actually described hypertrophic lupus. And the confusion has been so vast that a major journal, JAMA Dermatology, had to issue a statement on this. So as you would notice throughout the presentation, Behcet's is a complex multi-system disorder, which has remitting and relapsing course. And there are no unique histological laboratory features to really identify it. So what we really have are clinical features to go by. And interestingly, it shows geographic distribution in terms of its clinical spectrum as well. So let's begin with the case. This is a 38-year-old man with blurring of vision of the right eye who developed this in early 2015. And by August 2015, he had developed a right lower extremity DVT. He underwent 3 months of anticoagulation, and the DVT recurred. He went off anticoagulation in June 2016 with no further DVTs. However, he had a 10-year history of oral ulcers and 6-year history of genital ulcers and no rash. Progressive decrease in vision with near blindness of the left eye till by March 2019, and there was decreased vision in the right eye. So initial exam in the clinic in 2020 showed few pustular gum lesions, ulcerations, left eye blindness, and right eye was red with low vision. Investigations, ESR was modestly elevated, there was, CRP was significantly elevated, and the rest of the work was essentially normal. This is his ocular imaging, and as you would see that this is very aggressive eye disease with posterior uveitis, retinal vasculitis, and macular edema on the OCT. So Behcet syndrome prevalence varies from the Far East to the Mediterranean region and Europe. And it has the highest prevalence in Turkey with 370 patients per 100,000 population. There is a north-south gradient as well, with low frequency in the UK and high frequency, at least higher frequency in southern Italy. Immigration has had a major effect. If you look at Germany, people from Turkish descent have higher frequency of the disease than native Germans. So what I did over here is I combined 2 major papers with a significantly large Behcet's patients sample size into a single slide of comparison from the Far East, China, to the Mediterranean, Turkey. And you would notice that Behcet's not only has a varying prevalence with geography, but the clinical spectrum of the disease also changes. So in Turkey, there is female preponderance, and this may be different from China because perhaps because of the Chinese population structure. But if you look at the eye disease, Turkish people have much higher prevalence of ocular disease, and Chinese patients have much more CNS, vascular, and GI involvement. There is also a gender bias here. Turkish women have more eye disease, and Chinese men have more vascular involvement. Oral ulcers and genital ulcers are very frequent and very important characteristic of Behçet's, but there's no difference in terms of gender or in terms of geography. CNS lesions as well as GI involvement is also of equal distribution from the Mediterranean to the Far East, as well as between men and women. There is an age gradient here. So vascular involvement is more common in people more than 40 years old, as well as GI involvement, but genital and oral ulcers are not affected by age, at least in Chinese patients. There is mortality associated with Behçet's, and this is a study involving more than 800 patients followed for about 8 years. Higher mortality is observed in men, especially those who were less than 35 years of age. So you would notice that there are a large number of clinical features associated with the disease, as in any syndrome. And this review in Nature Reviews Rheumatology identified strong distinguishing clinical features for Behçet's. Oral ulcers are a must. If they are not there, then consider another disease. Genital ulcers are scarring in nature. Eye disease is very aggressive, and I will go over some of the features ophthalmologists can use to distinguish Behçet's from other autoimmune eye disease. And pulmonary arterial aneurysms are a rare but unique feature of Behçet's, and brainstem atrophy is another similar finding which is unique to Behçet's. So if you remember this slide, you would probably get the gist of it. There are oral ulcers, there are scarring genital ulcers, there are skin lesions which pustular vasculitic in nature. There can be erythema nodosum or pyoderma gangrenosum. And if you biopsy these lesions, there may be neutrophilic infiltrate or leukocytoclastic infiltrate. Eye disease is very aggressive, usually panuveitis. There's retinal vasculitis and also macular edema, which is the cause of blindness. There's arthritis, and you can add pulmonary and GI involvement here to complete the spectrum. And neuro-Behçet's has classic brainstem atrophy, and sometimes there can be cranial and peripheral neuropathies as well. Mortality is low, about 5%, but more in young men, and usually due to arterial involvement, pulmonary artery aneurysms which bleed, GI perforation, and CNS disease. There's something called the Pathogenic test, which involves, pouring using a high bore needle into the subcutaneous tissue, and it causes within 48 hours a neutrophilic infiltrate and lesion, which can be pathognomic for Behçet's and can be used as a clinical test as well. Ocular involvement, this is really very aggressive, as I told you. Bilateral eye involvement is most of the time. There's panuveitis, there's retinal vasculitis and vitreitis, which is at very high frequency, 90%. There's half the patients present with retinitis, and macular edema is the most common complication, which causes blindness. OCT and FFA are gaining ground in helping make the diagnosis. And at least half the patients require multiple immunosuppressives to control the disease. Hypopion, which is in the anterior chamber, is actually not very common. And this can be compared with higher frequency in spondyloarthropathies. There is progressive blindness, and the risk increases with time to about 30% at 20 years, especially in men. CNS involvement, brainstem atrophy is characteristic, and the major differential here is multiple sclerosis. However, the MRI, there is a clear difference between the lesions on MRI. This Bechet is a vasculitis, so there are large, extensive lesions. CSF has low pleocytosis, low WBC count, and oligoclonal bands are usually not present. Mortality is much higher, and there is significant disability as well. So very important to look into these things very carefully. GI involvement mimics Crohn's disease, except that on endoscopy, there are single deep round ulcers in the terminal ileum that perforate and cause massive bleeding. Vascular is a cause of very high, much higher mortality, 25% in 7 years. And the involvement is most commonly with DVTs in the lower extremities and superficial ulcerations, as shown here. There can be Budd-Chiari syndrome, inferior vena cava syndrome, or pulmonary artery aneurysms, as shown here, which are major causes of mortality as well. There can be intracardiac thrombosis and cerebral venous sinus thrombosis. And most people, most patients experience their first vascular event within 5 years of disease onset. So coming to treatment, the mainstay is glucocorticoids, and some immunosuppressives are preferred over others. So azathioprine, cyclosporin, infliximab are generally preferred, and cyclophosphamide is reserved for more severe organ involvement. Coming to mucocutaneous involvement, you see the treatment is individualized. So if the ulcers are, of low intensity, then you can use topical steroids. Colchicine also helps very much, but mostly in erythema nodosum rather than in oral ulcers. There is some data showing effect of anakinra, but secukinumab and tocilizumab are not helpful. Ocular disease, aggressive, so high dose steroids are needed. Cyclosporin, higher doses are used and there is risk for hypertension here. Infliximab is preferred choice. Adalimumab is also used, and there is data which shows dramatic improvement with interferon alpha, and there is variable experience with in terms of choice between infliximab and interferon alpha, depends on the center. The other immunosuppressants that are used are azathioprine, methotrexate, mycophenolate, and cyclophosphamide and rituximab have shown significant responses for ocular disease. So if we were to look at this entire table of drugs and the various subtypes of Behcet's involvement, if we were to focus on the uveitis, we would realize that there are the drugs that are used here are also used in other major organ involvement, vascular involvement, and CNS disease. So, the choices that are readily available in Pakistan are azathioprine, cyclosporin, cyclophosphamide, TNF inhibitors, especially infliximab, tocilizumab, and mycophenolate. In terms of CNS disease, cyclosporin is contraindicated. It actually exacerbates CNS disease. And for GI disease, azathioprine and infliximab are used. So continuing with the treatment, a few minor points in terms of usage of colchicine, erythema nodosum, and arthritis are more pertinent indications. Thalidomide can be used. We don't use it as much, but it's good for oral ulcers. And rituximab can be used for severe ocular disease, so also mycophenolate. And etanercept is also useful in oral ulcers, but not very good for pathogen. In terms of DVT, the anticoagulation is not as important as immunosuppression here, because this is a vasculitis and not so much of a hypercoagulability issue. No presentation can be complete without COVID-19 these days. So Behcet does not increase the severity of COVID-19, and treatment is not a contraindication, should be continued in general, and vaccination is definitely recommended. So coming to pathogenesis, the most significant association and consistently identified in Behcet syndrome is HLA-B51, which is an MHC class 1 molecule. Other other genes that are involved are IL-23 and IL-10 that have been shown to be associated. If we look at the gene expression pattern of the various subtypes of Bechet, you would notice that mucocutaneous gene expression is very different from the ocular subtype, and which is again different from the vascular involvement. And this is evidence that Behcet syndrome is a syndrome rather than a disease, and consists of multiple subphenotypes. So here is HLA-B51, and the next door is the ERAP1 protein, which is involved in trimming peptides for presentation to the MHC class 1 molecule. And over trimming or under trimming can lead to innate and adaptive immune system dysfunction and hyperresponsiveness, which can lead to the autoimmunity seen in Behcet syndrome. You would notice here that there are HLA-B51 is an MHC class 1 molecule, and another MHC class 1 molecule, HLA-B27, is associated with ankylosing spondylitis. Furthermore, you would notice that NOD2 is a major gene for Crohn's disease as well, and IL-23 receptor is also involved in Crohn's disease. So here now the clinical features and as well as the treatment strategies would be coming together. There is a similarity between Behcet's and spondyloarthropathies, which you will be able to see. So in terms of the sacroiliitis that is there in 10% of Behcet's patients, the eye involvement, the skin disease that is present, and in terms of treatment, the use of TNF inhibitors in both diseases are, bridges in terms of similarity here. So that will put these concepts together and help the clinician take appropriate decisions. Very interestingly, there is a concept of MHC1-opathy, which has been proposed, and earlier on, Behcet's was actually classified together with spondyloarthropathies, which is obviously changed now. But MHC1-opathy is a concept that it will probably move further into the future. So here is my effort in Bechet's genetics. This is unpublished data. I'm presenting for the first time in PSR 2021. Of course, there is a major locus at chromosome 6, which is the HLA-B51, but I've identified novel loci on chromosome 7, 3, 4, and 12 and 13. So if you're interested in my methodology, I refer you to this paper recently published that I did in association with Jerry Pedrera's group in Spain, and we show that DDX11 is a major gene increasing susceptibility in lupus. And the methodology that has been used here is based on my algorithm OASIS, which is also what I used in Bechet's genetics that I just showed you. So here we showed that DDX11 is suppressed in lupus patients and can potentially be used as a clinical biomarker, of course, after extensive clinical trials to be able to determine that, but there is hope for this. So here's the old Silk Route. And here's the new Silk Road, the Belt and Road Initiative of China. And the interest in the Silk Route has increased because of the BRI initiative. And recently, the Aga Khan Foundation sponsored a photographic exhibition in London to document the beauty of this region. And the Belt and Road Initiative is going to create new genetics and impact human health and disease in the future. And this will be the topic for someone else in another century to untangle. So thank you so much.